So, hello, welcome to next lecture from histology, and you see that today at this topic and today's lecture will be about the basic structure and a little bit the basic function of the most important endocrine glands in a human body. So we will concentrate on the basic endocrine glands, as you see already, for example, the hypophysis, the suprarenal gland, or the thyroid gland. We'll speak a little bit about the islets of Langerhans on the end. Before we start speaking about those endocrine glands, so a little bit as a small intro, we can also here explain the hormonal signaling. That means how the cells can react after gaining the right hormone. For example, the peptides and proteins can be attached to the receptor, to the protein receptor, which is in the cell membrane. That means the surface cell membrane receptor catches the right hormone. Yes, and this is starting a system, and this is activating a system inside the cell, that the product of the system will be so-called a small molecule, so-called a second messenger. The second messenger, as you see, is here in this moment, and it can be, for example, the cyclic adenomonophosphate, or the cyclic guanosine monophosphate, or the diacylglycerol, or inositol 3-phosphate can be it, or calcium ions, as you see, can be. So these are the second messengers in this moment, and they are activating inside the cell a new system that the cell can produce a bigger amount of hormones, bigger amount of proteins, bigger amount of steroids. So this is important, this one first system, the cell surface receptor. The second possibility is not on the surface, but inside the cell. Inside the cell is a receptor for a hormone, for example, in the nucleus. This we can speak about steroid hormones in this moment. And when it's attached this hormone to this receptor, this is activating, for example, this enzyme, polymerase, and in this moment we can see the higher transcription, higher or more activated transcription in the nucleus, and we have a bigger amount of messenger RNA in this moment, and messenger RNA coming out from the nucleus into the cytoplasm. And you know that messenger RNA is important for intensive proteosynthesis. So the proteosynthesis is running higher and is more activated in this moment. Yes, so these are these two possibilities. That one possibility is a receptor in the cell membrane for the hormone, and the second possibility is a receptor, for example, inside the nucleus. Okay. Ways of secretion. So here we have some basic four basic types. For example, on the first picture you see that the cell releasing the hormone by exocytosis, and this hormone, as you see, has an influence and is attached to the receptors on the same cell that was releasing the hormone. That means when it's the influence on the own cell, then we call this as an autocrine secretion or autocrine type of secretion. On the second picture you see that the hormones are released by exocytosis from this cell, and these hormones has the influence on the closest cells just near this cell producing the hormone. So for example on this cell or on this cell, and you see that the cells has got the receptors for this hormone, and at this moment when it's the closest cells this cell has influence on the closest cells around, we are speaking about the paracrine type of secretion. I think that you know very well this most common possibility that the hormone is released by exocytosis into a capillary. Yes, it can be into a sinusoidal capillary, fenestrated capillary. Yes, in some endocrine glands, and by blood is taken this hormone away from this endocrine cell, and by blood is taken to the another organ, to another cell, and having influence on those cells. Automatically we call this, what you know, I think the best, endocrine type of secretion. In the moment, there is the help of a mediator, which is released into the synaptic cleft. So we are speaking about a synaptic secretion. Synapses, I think you know from the nerve tissue, where they were a little bit more explained in detail. The next very important thing is as well polarization of the endocrine cells. That means when this is an endocrine cell, that means that the hormone is released, for example, on this scheme, into the blood, into a fenestrated capillary. That means not into a duct, like you would see, or as we see in exocrine cells, exocrine. But here, the hormone is released into the blood. That means the orientation of the most important organelles in the cell, for example, rough endoplasmic reticulum, or for example, the Golgi apparatus, logically has to be orientated, or those organelles has to be orientated more in the direction to the capillary, and not on the opposite side. There is not the capillary and there is not the blood. So I think that this scheme is showing very nicely the orientation and the localization of the Golgi apparatus, the localization of the rough endoplasmic reticulum before, yes, with the nucleus, yes. Even you see nicely the nucleolus, here is a nucleus, and here is a nucleolus. So the polarization of the endocrine cells, this time the localization of the organelles, for example, on this scheme, yes, to the closest capillary. So, and today we can speak, and we will speak about the hypophysis, then we move to the epiphysis, yes, to the pineal gland. Then we will be speaking about the thyroid gland, yes, few words about the parathyroid glands. Then we move a little bit lower in the human body to the suprarenal adrenal glands, and few words also about the endocrine part of the pancreas. And those endocrine part of the pancreas is represented by the islets of Mr. Langerhans. I think that you know already from other systems some ideas where we can speak about endocrine function or endocrine cells producing hormones. I think that very not far ago was the urinary system, so I hope you can remember the juxta glomerular apparatus in the kidneys producing renin, yes. Or now we have the male and female reproductive system, so I think you can remember the Leydig cells in the testes producing testosterone, or the cells in the ovaries producing progesterone and estrogens. Placenta is a very important organ, also with an endocrine function, please, also with an endocrine function. This abbreviation, diffuse neuroendocrine system, you have heard already, together with the respiratory passages, I think, and with the digestive tube. Yes. So, let's concentrate mainly today on those red colored endocrine glands. The most important parenchyme, logically parenchyme, yes, in those glands is from is an epithelium, is a secretory epithelium producing hormones. I think that the dominant type is a trabecular epithelium in many endocrine glands, trabecular epithelium, yes. And in the thyroid gland, they are not trabecules, but the epithelium is arranged in round structures which we will see on a section in the microscope later on a slide. And those round structures are called follicles. So this is a follicular structure in the thyroid gland, not a typical trabecular epithelium. And of course, a part of the hypophysis is neurohypophysis, where we will see axons, yes, axons from neurons, and around those axons are also neuroglia cells called pituitarides. And in the epiphysis, we will see modified neurons, which can produce a hormone, and of course also in the pineal gland epiphysis are neuroglia cells present. And the secretory epithelium has to be surrounded by the reticular connective tissue, forming such a basic holding stroma by reticular fibers and some cells for all this secretory epithelium. And here you see the hypophysis. Pituitary gland, glandula pituitaria in another name, hypophysis, with the bigger anterior lobe, which is called adenohypophysis, and the smaller posterior lobe, which is called neurohypophysis, posterior lobe, yes. This posterior lobe is connected to the hypothalamus by this connecting stalk, or in the right name, infundibulum. The weight, you see, it's a very small, 1 centimeter. It's a very small gland, not very heavy. And ladies, after several pregnancies, can be the weight can be a little bit higher. It can be more heavy, a little bit more heavy. Where to find hypophysis? So if you know a little bit the bones of the skull, so this is, you see the basis of the skull, yes, and here this bone is called, I hope you know, sphenoidalis, the sphenoid bone, and the middle part is called the corpus, the body of this sphenoid bone, corpus ossis sphenoidalis, and here in this region is a small hole on the upper surface, which is called fossa hypophysialis, and in this fossa, in this small hole, is sitting the hypophysis. Yes, so this is the place where to find it. In some books, you can even find the name of this place, Sela Turcica, because to someone it reminds the Turkish saddle, and I think that you feel this hole, something like fossa hypophysialis here. So, adenohypophysis, if you will hear in few weeks, has an ectodermal origin, and of course neurohypophysis is from neuroectoderm. So there are two origins, and these two bases are slowly coming together, connecting together, and the whole hypophysis is ready. Yes, the infundibulum is connecting neurohypophysis, the posterior lobe, to the hypothalamus, please. And here you see on the scheme the hypophysis, yes. This is the adenohypophysis, and this is the neurohypophysis. And this is the connecting stalk, yes, infundibulum, and this is the area of hypothalamus, please. So, this, if you know from anatomy, is called chiasma opticum, yes, this place. And now here is the accumulation of neurons in hypothalamus. So we can even see a part ventrally, which is called so-called the anterior hypothalamus, the central hypothalamus and the posterior hypothalamus. So here are the three parts of the hypothalamus, and now the accumulation of neurons is clear that you can distinguish so-called the nuclei in the hypothalamus. So in the anterior hypothalamus you can see this bigger one is nucleus paraventricularis, and above chiasma opticus is called this nucleus supraopticus, above chiasma opticum, so supraopticus. Yes, in the middle part you see the nucleus dorsomedialis. Yes, you see the ventromedial nucleus and nucleus arcuatus. This is the lower one. Yes. And in the posterior part of the hypothalamus, you can see the posterior nucleus. Nucleus posterior is this one. Yes. And now you see on this bigger scheme that the neurons are sitting in the nucleus, that means here, and axons are leading and running down through the infundibulum, yes, and ending, as you see, in the neurohypophysis. Here is the end of those axons. They are even forming such pathways which are called tractus. So logically, this tract from this nucleus paraventricularis is called tractus paraventriculo-hypophysialis, and the pathway from the supraoptic nucleus is called tractus supraoptico-hypophysialis. You see that the neurons in the nucleus arcuatus, for example, here, yes, from this nucleus, are also shorter axons called tractus tubero-hypophysialis, and ending, not running completely down to the posterior lobe, but ending in the infundibulum. So a little bit division of the hypothalamus into the anterior part, central hypothalamus and posterior hypothalamus, and the basic names of nuclei important in the hypothalamus. So in those nuclei are sitting the bodies of the neurons, and the axons running from these two important nuclei down through the infundibulum to the posterior lobe, to the neurohypophysis. So a simple scheme that you see, this one part, a bigger part, is the anterior lobe, adenohypophysis, the anterior lobe, and this is the posterior lobe, neurohypophysis. The infundibulum you see here. So yes, the anterior lobe has three basic parts. The most biggest and ventral is so-called pars distalis, so this is this part. The smaller part, which is slightly surrounding the infundibulum, is pars tuberalis of the adenohypophysis, and this part on the, I would say, borderline between adeno and neurohypophysis is pars intermedia. So, as you see, the whole hypophysis is surrounded with a thin capsule from a connective tissue. It's coming down, this capsule, from the hypothalamus, so it's in fact pia mater, this loose connective tissue surrounding completely the hypophysis. So automatically trabecular epithelium in the anterior lobe, and sinusoidal capillaries, please, and sinusoidal capillaries. So here's the perfect capillary net around those trabecles of the secretory epithelial cells, that the hormones can get into the blood from those epithelial cells with any problems. In the neurohypophysis, of course, many axons, yes, you know where are the neurons, the bodies are sitting in the nuclei in the hypothalamus. So the axons here coming down, and the axons ending at a system of fenestrated capillaries in this region. So here are ending the axons. Yes. that the two hormones which are produced in the hypothalamus can get with any problems into the blood from the axons by exocytosis, and the cells of neuroglia are called in neurohypophysis pituitarides, please. So you see the nuclei on the scheme of many pituitarides, yes? Good. So let's move now in detail a little bit to explain the adenohypophysis, the anterior lobe of the hypophysis. You see on this scheme, or from this picture from a slight microscope, many cells orientated in those irregular trabecles. So you see the trabecular epithelium, as you see, nicely seen the trabecles in some parts, yes. So, and now the basic staining methods. For example, on this picture, hematoxylin eosin. You can use another staining method. For example, yellow trichrome, Eisen method, Weigelt-Van-Giesen method, and always by those basic staining methods, we can distinguish, I would say, two basic types of cells. One's chromos is color and phileo is to love. So one big group of cells which are stained by a dye, chromophilic cells, and the second group, chromo, color, and phobeo is to be afraid. I hope you know this translation. And that means cells that the granules and the cytoplasm will be not stained. So you have a feeling that those cells hasn't got affinity not to a basic type, not to an acid type of dye, so logically chromophobic cells. And now, if the granules in the cytoplasm has the affinity to an acid type of dye, so logically chromophilic cells we can distinguish into acidophilic, one possibility, and they have affinity to a basic type of dye, so basophilic cells. So chromophilic cells are acidophilic and basophilic cells. Chromophobic are chromophobic cells, please. As you see, the cells with this nicely eosinophilic cytoplasm are chromophilic cells, yes, and acidophilic in this moment. In number, they are also dominant in adenohypophysis. About 40 to 50% are occupying chromophilic and acidophilic cells. Lower number are basophilic cells, as you see with this dark cytoplasm, basophilic cells, yes. And then cells that you see perfectly stain the nucleus, that's true, because hematoxylin is staining nuclei, but we have such a feeling that the cytoplasm is slightly not stained, as you see, for example, at this cell, or for example, at this cell, you see the cytoplasm is slightly white, so those are chromophobic cells, for example. Please, those small elements here in this, here is a nucleus of a endothelial cell, so you see a wall of a sinusoidal capillary here on the section, and in the sinusoidal capillary we see accumulation of erythrocytes at this moment. So this is such a basic staining method, hematoxylin eosin, on this picture, and we can distinguish nicely those chromophilic and chromophobic cells, and chromophilic cells we can distinguish acidophilic or basophilic cells. But now, to understand which cells are precisely producing this type of hormone, you need only very clear immunohistochemical method. Then you need immunohistochemistry, and by this method you will very nicely understand that this type of cells is producing only, for example, follicle stimulating hormone. This type of cells are producing only thyrotropic hormone. And this type of cells are producing the growth hormone, and so on and so on. The chromophobic cells, the biggest number of chromophobic cells are so-called folliculostellate cells. You see them here. They have such longer processes, those cells, and they are forming such a holding apparatus for the other types of cells, for the chromophilic cells. So the biggest number are the folliculostellate cells of chromophobic, and a lower number can be young or very old chromophilic cells, young developing chromophilic cells, or dying old chromophilic cells. So chromophobic cells are folliculostellate cells or young or old chromophilic cells. Here is a gonadotropic cell. You see nicely the nucleus and the nucleolus, yes, and you see the granules containing a hormone, yes, very nicely. And now a little bit to the function of those cells. So you see the one group of acidophilic cells and a little bit bigger group of basophilic cells. So now we are speaking about the chromophilic cells producing hormones intensively. So there are two types of acidophilic cells. So somatotrop, growth hormone, yes, as you see here, growth hormone, yes. And the second is prolactin. Prolactin also belongs to the acidophilic cells, and this is this one, yes, prolactin. So, of course, influence you see on what? Now the basophilic cells, the second group, basophilic cells. So, TSH, thyrotropic hormone, basophilic, this one, having influence, of course, on the thyroid gland. Yes, thyroid stimulating hormone, thyrotropic hormone. Now the second group, gonadotropic cells. Gonadotropic cells, FSH, follicle stimulating hormone, basophilic, yes. FSH, yes, stimulating the growth of the follicles in the ovary, as you see on this picture. The second type is LH, luteinizing hormone, yes. Very important, his level is just coming up very intensively just in front of ovulation. And in this moment, gentleman has got interstitial cell stimulating hormone, having influence on Leydig cells in the ovary to produce the higher level of testosterone in this moment. And the corticotrope cells, this is another group. So this was the first one, this was the second, and this is the third group, corticotrope cells, and you see ACTH, adrenocorticotropic hormone, this is this one, next basophilic type, yes, and this is adrenocorticotropic hormone on the cortex of the suprarenal gland, influence, yes. And the second, MSH, melanocyte stimulating hormone, melanocyte also basophilic, melanocyte stimulating hormone. This is acidophilic, I should make here A, and here I should make A for you. And these two types are clear, and 4 types of basophilic, yes, that's true. And melanocyte stimulating hormone, which is having influence on melanocytes, which are cells present in your epidermis, the first layer of the skin, epidermis, and there are many melanocytes, and they are producing the pigment melanin. So the influence on the higher production of melanin in this moment. And the cells also can produce beta lipoprotein, beta endorphin, or enkephalin. So this is still a small group of hormones can be produced. So this is such a small repetition or intro, if you want, of the acidophilic cells, 2 types, and the 3 basic types of basophilic cells, of the chromophilic cells in adenohypophysis. The second very important thing is not the basic staining methods or immunohistochemistry, but electronograms. Electronograms from an electron microscope. And now we can distinguish slightly the types of cells also thanks to the electron microscopical pictures, the electronograms, because the size is important and density of the granules So thanks to the size of the granules in nanometers, we can also slightly distinguish, for example, you see the somatotrope cells, you see the granules in this very nice moment, yes, in the cytoplasm. You see the rough endoplasmic reticulum here, yes, very nicely, but the granules are present here. You see the nucleolus in the nucleus, yes. Yes, and now the corticotrope, you see 100 to 400. So, these are the granules in the corticotropics. I would say smaller, and not so many. And this in the corner is a small part of the cytoplasm of the mammotropic cells and the granules. You see in this cytoplasm very nicely here. So you see also the accumulation, density of the granules, the size of the granules. So also by this possibility of electron microscopical pictures, electronograms, we can also slightly distinguish the basic types of cells. So you don't need always to do immunohistochemical methods, but also electronograms can help you. Now we are back in the light microscope. The staining is ASEN method, yes, one of the basic staining methods, ASEN. And now we see this darker part on this picture, and this is the adenohypophysis. We know already the trabecular epithelium, and you see the sinusoidal capillaries, yes, inside. And now we have been speaking about the chromophilic and chromophobic cells. And this lighter part, just near to it, is neurohypophysis. And now this part between is pars intermedia. So this is a borderline between these two lobes, between these two important lobes. And here we see a little amount of loose connective tissue. In this loose connective tissue can be groups of basophilic cells present, yes, basophilic cells. And here we see bigger vessels, arteries and veins, yes, in this moment. And the last thing, we can see such small round follicles, if you want, or cysts, lined with a simple cuboidal or simple squamous epithelium. Such a remembrance on the development of hypophysis, because in few weeks you will be listening to the development of hypophysis, embryology moment, and there we will hear about something what was called the Radke's cyst, and those follicles is the remembrance of this cyst of Mr. Radke in pars intermedia. So this is the middle part, yes, such a middle connecting part between adeno and neurohypophysis, pars intermedia. Here is a detail from neurohypophysis. So you see it's a lighter part in a light microscope by basic staining methods, that you see some arterioles, venules, the system of fenestrated capillaries. The lighter parts are the long axons coming down here from the hypothalamus, from the neurons lying in the hypothalamus. And the dots which you see here are the nuclei of neuroglia cells, which we call pituitarides. So, and two hormones, which are, as you see, not very large proteins, they are consisting only from 9 amino acids, are transported from hypothalamus, from those neurons, from the bodies of the neurons, by those long axons down to neurohypophysis, and they are leaving this axons by exocytosis, and they are released to the blood. So one of those two hormones is antidiuretic hormone, ADH, in another name vasopressin, and the second hormone is called oxytocin. So these two hormones are produced in the hypothalamus and transported through the axons, attached to a transporting protein which is called neurophysin, and with this protein, with this neurophysin, these two hormones are transported to the ending of those axons and released into the blood. Pituitary we call or we take to the macroglia cells. Macroglia because they are very big cells with long processes, reminding a little bit astrocytes from neuroglia cells. So we call them, or we take them to macroglia cells. Antidiuretic hormone, antidiuretic hormone, please, antidiuretic hormone. Having influence on the collecting tubules, in the kidney. Yes, that the cells in the collecting tubules are gaining more aquaporins in the cell membrane, and water is absorbed. You know that our normal amount of definitive urine in 24 hours should be between 2, let's say maximum 2.5 liters of definitive urine. And now the problem is that the patient suddenly can have a big volume of definitive urine. That means, for example, 20 liters or even 30 liters in 24 hours. That means that the hormone is missing, not having influence on the collecting tubules in the kidney, and the problem for the patient is starting. This disease is called, in a nice name, diabetes insipidus, and the patient is losing a big amount of urine and of course of water in 24 hours, so it's very dangerous. So of course the patients are as well drinking very much of water in 24 hours, and when they come on the reason why there is missing this hormone in his blood, why it's not produced in the hypothalamus, the reason can be, for example, can be a cancer of the hypothalamus in this moment. Oxytocin is the next polypeptide from 9 amino acids, and this hormone is getting to the blood from the axons here and having influence on smooth muscle cells. Mainly in the myometrium of the uterus, for example, and the contraction is more intensive and quicker of the smooth muscle cells, having influence on myoepithelial cells, for example, in the mammary gland. There are present myoepithelial cells in the mammary gland around the secretory cells, so the higher and quicker production by those secretory cells and releasing the milk into the duct. So here you see the system of capillaries in the neurohypophysis. You see coming the axons to neurohypophysis. You see nucleus paraventricularis and the bodies of the neurons, and you see supraoptic nucleus, and here are sitting the bodies of the neurons, and there are axons running through the infundibulum, to the neurohypophysis, and the hormones released to the blood from the axons. This is the pars intermedia, and this is the adenohypophysis here, as you see. This is a picture of the body of the neurosecretory neuron. This is the body of the neurosecretory. You even see the light nucleus and the nucleolus. You see the basophilic cytoplasm, typical basophilic cytoplasm, very short dendrites, and this can be, for example, the long axon, which is coming down and bringing the hormones to the ending of the axons and then release to the blood. As you see, Mr. Herring has described such bodies in the axons, so we call this accumulation of hormones in those bodies as Herring's bodies. So we see them by special staining. We can even see them by special staining. Yes, by special staining in the axons in neurohypophysis. You see the mitochondria and the microtubules, yes, for the transport, very important. And on the ending of this axon is released the channels, helping by calcium, and the hormones by exocytosis are coming into the blood, into the fenestrated capillaries. You see the diaphragm in the fenestration, so these are fenestrated capillaries nicely in the neurohypophysis. Here you see the endothelial cells in the capillary, yes, and here is the blood. And the hormones released from those granules can get to the right cells. Yes, the antidiuretic hormone to the collecting tubules or to the cells of the collecting tubules in the kidney, and oxytocin to the smooth muscle cells. And the last very important thing is the portal system in the hypophysis. Portal system in the hypophysis. You know about, I hope, a portal system in the digestive system. That you know that we have the portal vein coming to the liver. So as another portal system, this time is in the hypophysis. Portal system generally means that there is one capillary net, and a second capillary net. And these two capillary nets are connected by a system of portal veins or a portal vein. These two capillary nets. So this is the first capillary net, and this is the second one. Yes, and they are connected by, as you see in this moment, by very short but few portal veins. So where is the first capillary net in our problem in the hypophysis? The first capillary net is in the infundibulum. As you see, the infundibulum, the nutrition and the capillaries are from arteria hypophysaria superior. So this is the first capillary net. And the second capillary net is in the adenohypophysis, and these are our famous sinusoids or sinusoidal capillaries, which I was showing a sinusoidal capillary a few minutes ago on another picture. And this first capillary net and the second capillary net are connected by very short but several portal veins. Neurohypophysis. These capillaries around the axons are branched capillaries from arteria hypophysaria inferior. Yes, so this is only one capillary net in neurohypophysis, and these two hormones, antidiuretic hormone and oxytocin, can get into the blood. And now why this system is here between the infundibulum and the adenohypophysis? It's very simple. To get very important factors, hormones, hormones. I would say the best is hormones from the hypothalamus, from those neurons of the nuclei in the hypothalamus, very quickly to the adenohypophysis. And this can be very important releasing factors. In another name, liberins, releasing factors, yes, because each hormone produced in adenohypophysis has got his own important liberin or releasing hormone, releasing factor. And also can get here by blood some inhibiting factors from the hypothalamus, inhibiting factors to the adenohypophysis. So it is a shortcut, I would say a very important shortcut between this place and adenohypophysis. hypophysis, between the infundibulum and the adenohypophysis. Because the cells, here are controlling the level of hormones from the cells in the periphery. Let's say a very simple example. So the cells are controlling in the blood the level of the hormone, for example, thyroxine in the blood. Thyroxine is a hormone produced by the thyroid gland, and it's pushed out into the blood. When the level is very low of thyroxine in the blood, those cells are reacting, the cells in the hypothalamus are reacting on this situation, and they are producing liberine, which is called thyroliberine or thyroleberine, a very short polypeptide, thyroleberine, and a very short polypeptide is only from 3 amino acids, and they are pushing out this thyroleberine into the axons, and by the axons it's coming to the capillaries, released into the blood, thyroleberine in the infundibulum, by the portal veins, coming quickly to adenohypophysis. And now, if you remember, having influence on the thyrotropic cells in adenohypophysis, and they will produce in this moment a higher level of thyrotropic hormone. And this higher level of thyrotropic hormone gets into the blood, quickly by blood to the thyroid gland, and the cells in the thyroid gland will release a higher amount of thyroxine into the blood in this moment. So is the reason why it has to work here, the very important portal system in the hypophysis. Older histologist has even got a name for this, rete mirabile venosum, a miracle, a miracle net of veins in the hypophysis, rete mirabile venosum. Interesting but very nice historical name for this simple system of very short portal veins between one capillary net and second capillary net. So it's working. So each hormone produced here in the adenohypophysis has got his releasing factor, of course, or liberine. I think it was enough about hypophysis. I hope to understand the basic structure and function. And let's move now to this very small gland which is here on the ceiling of the encephalon, and this is the pineal gland or epiphysis, corpus pineale epiphysis. Of course, as well covered completely by a capsule on the surface. Then this, of course, is pia mater when we are in the brain. So now let's look on the histological structure through this small gland here, epiphysis. And here you see by hematoxylin eosin a nice small section, a part through this pineal gland. So on the surface you see a capsule from more dense connective tissue or slightly loose connective tissue, but perfectly blood supplied. And these vessels are perfectly dividing into arterioles and of course venules in very thin septas which are running through the whole epiphysis, and you see the thin septas with the small veins and venules and arterioles. So perfectly you see on the section the thin septas here. Yes. Now the stroma. So the bigger number are modified neurons, which we call pinealocytes. You will see a detail. So many of those nuclei belongs to those pinealocytes. When they are modified neurons, we will see nicely the typical nucleus for a neuron. And the second type of cells are once more neuroglia cells, which are very similar to astrocytes, and the nucleus is also typical for those neuroglia cells. On another picture I will show you such calcified bodies which are typical in an older person, in an older age, higher age, and these calcified bodies are typically called corpora arenacea or acervulus cerebri. Acervulus cerebri, in another name, corpora arenacea. And here we see nicely now in a detail. So these are, let's start with the typical structures, and those are the lamellar structures, the corpora arenacea. Here you see here with a lower magnification and one with a very big magnification. And now I see the typical light nucleus, and here and here, and typically light nuclei, sometimes with a typical nucleolus inside, typical nucleolus, and those are the nuclei, and slightly you see stain the body of pinealocytes, for example here, yes. And the darker nuclei, smaller and darker nuclei, belongs to the neuroglia cells, So, and those our famous modified neurons, pinealocytes, their function is very simple. They have two important enzymes in the cytoplasm. In the cytoplasm they have two important enzymes. This one enzyme, both are transferases. This one enzyme is called SNAT, SNAT, and the second transferase is called HIOMT, HIOMT. So T transferases, and this first enzyme is converting serotonin into such a half melatonin, and by the function and by the work of the second transferase HIOMT is this step, this between step, is converted to the definitive melatonin. Yes, the enzymes are very active without daylight, at night when it's dark. So they are mostly active, as they have counted, around the 3rd hour to the 5th hour in the morning, in night. And those enzymes are actively converting serotonin into melatonin. Yes, so this is the function of those pinealocytes in the pineal gland epiphysis. And maybe you will be lucky to see on your slides this corpora arenacea, a typical sign in a higher age. These calcified bodies, they have such a lamellar structure, concentric lamellar structure, these calcified bodies. So let's move a little bit lower to the neck region, and here you see nicely the cartilagothyroidea, the thyroid cartilage. This is this one, thyroid cartilage, nicely. You see the rings in the wall of the trachea, hyaline cartilage, and somewhere at this level you see the isthmus of the thyroid gland. The isthmus of the thyroid gland is on the level of the first or second ring of the trachea, and you see this nice lobus dexter, the right lobe, and you see perfectly the left lobe, lobus sinister of the thyroid gland. And some of the people, they are saying around 50%, half of the population can have this small pyramidal shaped lobe. It's really called lobus pyramidalis, pyramidal lobe, remembrance on the development of the thyroid gland. How you will hear in few weeks or in few days, you will hear the development of the thyroid gland. And this pyramidal lobe is such a remembrance on something what was called here ductus stereoglossus during the development of the thyroid gland. So, the whole thyroid gland is surrounded by a capsule from connective tissue. In the same capsule, we can then find on the posterior wall, on the posterior wall, we can or surface we can find the parathyroid glands covered with the same capsule, of course. Yes, good. Septas we will see in few minutes on the next pictures. And what is interesting, the blood supply. So you see the very important blood supply coming by here, thyroidea superior, this artery, and then, for example, thyroidea media, and here now the system of veins taking the blood out from the thyroid gland. Yes, and you see where they are opening. Yes, so this is important also. And here you see the nutrition of the thyroid gland in a bigger picture. So the thyroidea superior, inferior. Yes, so you see them nicely. And the system of veins, superioris media and vena thyroidea inferioris. Yes, taking out the blood from the thyroid gland. It's a very important endocrine gland, so the system of vessels has to be here very rich and very perfect to get thyroxine and 3-iodium thyronine, these two hormones, in the whole body. So this time, and this endocrine gland, let's forget on the trabecular epithelium, but we will be speaking about the follicular structure. The basic unit are thyroid follicles. The follicles are lined with, let's say, generally follicular cells, yes, and now the shape. Generally, mainly, we will see slightly cuboidal shaped, so they are representing a simple cuboidal epithelium, but of course sometimes we can see slightly columnar cells, as you see here, and even slightly sometimes squamous cells. It depends on the activity of those cells. So the follicular cells are nicely here seen on the scheme, lining this follicle and here this follicle and the neighbor follicle, so you see perfectly the follicular cells. You see just very near the basement membrane is a system of capillaries, because it's very important to take iodium from the blood and to push out by exocytosis the hormones back into the blood. So in this loose connective interstitial tissue is a perfect capillary net very near the follicular cells, This colloid, this name in the middle, in the center, the colloid is a mass, yes, gel-like mass, there is a storage and the production of those very important hormones of the thyroid gland. So the most important two hormones, as you can read here, are thyroxine, T4, T4, tetraiodium thyronine, and T3, 3-iodium thyronine and tetraiodium thyronine released into the blood. Function of those hormones very clear. Here's a nice picture from a light microscope. You see nicely the capsule on the surface. So this is the connective tissue of the capsule with some vessels. Yes, very nicely seen. And we see nicely septas, which are dividing the big lobe into smaller lobules, as you see, the septas with blood supply. And we see here many follicles on the section, many follicles with the colloid in the center. With a small magnification we can feel the follicular cells, yes, the follicular cells nicely. And we see the loose connective tissue around the follicles very nicely. So, and here is a small detail or a scheme showing a little bit the storage of the hormones in the colloid. So the first thing, you need a capillary. Yes, with endothelial cells, you know that capillaries are lined with endothelial cells. And now the cells are taking iodium from the blood. Yes, there are iodium pumps working, and the iodium is getting inside the follicular cells and transported over the cell to the apical part, and released into the colloid. Yes, and released to the colloid. Yes. The second is the rough endoplasmic reticulum in the cells and the Golgi apparatus, producing a very important protein, thyroglobulin. And you see the rough endoplasmic reticulum transported this thyroglobulin into the Golgi apparatus, vesicles in the Golgi apparatus, and they are transported to the surface, and thyroglobulin is released out from the cells, yes, into the colloid. Now happens the iodination of tyrosine rests. So if one iodium is attached, it's a monoiodium tyronin. If two iodiums are attached, it's diiodium tyronin in the colloid. If three, you have triiodium tyronin. You see three. And if even four, so it's tetraiodium tyronin or thyroxine in another name. So these hormones are stored in the colloid here. You see, attached to the thyroglobulin. And now, if they are necessary in the body, those two hormones, of course, they have to get back from the colloid, back into the cell, over the cytoplasm of the cell to the basement membrane, to the basal part of the cell, and to be released into the blood. So you see that the colloid is a very important storage of those two important hormones which are necessary for the cells in the tissues. Now they take absorption back of this system, of this structure. By lysosomes is released thyroglobulin, is released away. And here you see how the hormones without thyroglobulin are pushed into the blood. Yes. Of course, that the cell is using the rest of thyroglobulin and producing once more a new one, and once more a new thyroglobulin is pushed back into the colloid. So the system is running around here. And the hormones are in the blood at last. The rate proportion of thyroxine to triiodium tyronin is approximately 20 to 1. 20 to 1, 20 of this one to 1 of triiodium tyronin in the blood. But in the tissues is very active triiodium tyronin, this hormone. So in the tissues, thyroxine has to be converted into triiodium tyronin, and this is the active hormone for the basal metabolism. Here you see nicely the colloid in the follicles. This is the colloid, the mass. You see nicely the, I would say, cuboidal shape here, cuboidal shape of the follicular cells. Here is the basement membrane. Yes. So here are dominant cuboidal shaped follicular cells. Yes. You see capillaries around, the lumen of capillaries. Yes. Just near the basement membrane. And now here in this slight microscopical picture we see a second type of cells here and here and here and here, and those cells are parafollicular cells, in another name C cells. Parafollicular or C cells. C is the first letter of the hormone calcitonin, which are producing those interesting and important parafollicular cells in the thyroid gland. You see the nucleus is larger, much lighter. You even see the nucleolus. Yes, in the nucleus, here very nicely you see the nucleolus. Yes, very light cytoplasm. This is a typical sign of a parafollicular cell in the comparison to the follicular cells. Yes, granules, you see nicely, the size can be different from 60 to 550 nanometers. And calcitonin stimulates osteoblasts, inhibits osteoclasts, so logically the more matrix in the bone, the new bone matrix needs more calcium for mineralization, so the level of calcium is in this moment lower in the blood. So that's the function of parafollicular cells, C cells in the thyroid gland, producing this hormone, calcitonin. Here you see a colloid in the center of a follicle. This is the round nucleus of a follicular cell, next one, next one, next one. Here is a basement membrane, and here is a erythrocyte in a capillary. Yes, so this is the wall, and here endothelial cell. Yes, and here you see the parafollicular cell. Yes, at this moment, and those are the granules containing calcitonin in the cytoplasm of the parafollicular cell. The cells are sitting sometimes nicely between the follicular cells, the parafollicular cells. And the follicular cells are so slightly above, covering the parafollicular cell. That means that the lumen is never touching the colloid in the center. It's for nothing because calcitonin is released into the blood. So this is no reason that this parafollicular cell should be so high as a follicular cell. So this is clear, here's a nucleolus inside. And the second possibility that the parafollicular cells are sitting very near the basement membrane in the connective tissue, just very near a capillary, as you have seen on this picture. So here maybe those follicular cells are still on the basement membrane, and this follicular cell is already outside the basement membrane. So you see very near the basement membrane. So that's why it's called very near, parafollicular cells in the thyroid gland. A little bit that you know from life, that some patients can have the larger thyroid gland. It's called the goiter, enlargement of the thyroid gland. Of course, it's a very unhappy situation because the pressure of these big lobes can have the pressure on the esophagus, on the trachea. So there are problems with swallowing what you eat, and of course there can be problems with breathing as well. So the reasons why it's growing, these two lobes, can be different. The hyperfunction or hypofunction of the thyroid gland can happen, and the result is then seen so on the neck. So they have to take a small piece of the tissue from the thyroid gland, yes, by punction, and in the microscope they study the cells, and the reason they have to come on the reason, what is happening in the thyroid gland. Now let's move on the posterior part of the thyroid gland, and you are watching from the posterior view, from the back side, we are watching covered with the same capsule as the two lobes of the thyroid gland. So we are watching here two upper and two downer parathyroid glands. So these are the glandulae parathyroideae superiores, glandulae parathyroideae inferiores. So a normal situation is 4 parathyroid glands. This is the normal situation, that they should be 4, 2 upper, 2 downer. Can happen that some people can have an aberrant 1 more or 2 more parathyroid glands. Can quietly this normal happen. We are back in trabecular epithelium, please. Trabecular epithelium. So this is the basic parenchyme, trabecular epithelium. Of course, it's an endocrine gland. So in the septas between these trabecular epitheliums, perfect capillary net, and vessels, perfect. On some slides, you will see in older people more and more adipocytes, unilocular adipocytes in the parathyroid glands. It's quite normal situation. And now the 2 parts and the 2 basic cells present. So-called the chief cells. They are smaller, 5 to 8 micrometers large, and those cells are responsible for the production of the antagonist of calcitonin, and this is parathormone. Parathormone is the antagonist of calcitonin, so they are producing the cells. Chief cells are producing parathormone. Oxyphilic cells are not producing any hormone. You will hear in few days on the next lecture that they are from endoderm, parathyroid glands, so from so-called endodermal pouches, which are lined with endoderm, and they are developing from the 3rd and 4th endodermal pouch. And on this scheme, you see the chief cells. These are those producing parathormone, and those with the typically eosinophilic cytoplasm are those oxyphilic cells. Here we are using the word first. Phileo is to love. Oxys means acid. Oxyphilic cells are those in those groups. You see them here on the picture from the light microscope. So here are oxyphilic cells in this group here, yes. The first oxyphilic cells are seen around the age of 8 to 10 years. And then in an older person, more and more oxyphilic cells. The cytoplasm is typically eosinophilic thanks to a big amount of mitochondria. And the function is not very clear about oxyphilic cells in this moment. But in age, the number is increasing in age of oxyphilic cells in the parathyroid gland. Of course, the most important chief cells, which you see here, are producing parathormone, having influence on osteoclast, on the resorption in the digestive system, in the small intestine, having influence in the kidneys. That the result is to hold the level of calcium in the blood, as a higher level of calcium in the blood should be the result of this hormone. Of course, calcitonin and parathormone hasn't got, as you have been listening to my lecture, they haven't got any hormone from hypophysis. So these 2 hormones are released from the cells just according to the level of calcium ions in the bloodstream. There is not any hormone from adenohypophysis which would have influence on the parafollicular cells or on the chief cells here in the parathyroid gland. Here's a nice electronogram of oxyphilic cell in the parathyroid gland. So you see here the nucleus. Where's my pointer here? So you see the nuclear envelope. You see the nucleus with euchromatin, heterochromatin, very nicely. You see the nuclear envelope, yes. And you see how many mitochondria, with Christie, how many mitochondria are present in the cytoplasm of the oxyphilic cell. How many mitochondria are here present? So you see the rough endoplasmic reticulum is not dominant. So the cytoplasm is typically eosinophilic in this moment. Typically nicely eosinophilic. And let's move slightly to the suprarenal gland or adrenal gland, which you see on this anatomical scheme where they are orientated localization. That's the kidney, and that's the kidney. And on the upper pole of each kidney, you see the suprarenal gland on the left side, right side, the two suprarenal glands on the upper pole of the kidney. They are covered as a whole kidney. As a whole kidney, they are covered with the same adipose tissue which are covering the kidneys. That means capsula adiposa renis, capsula adiposa renis, the adipose tissue covering both. But of course, the kidney has got its own capsule fibrose, capsula fibrosa renis, and the capsule of the connective tissue is on the surface of the suprarenal gland. So then both has got separated fibrous capsule, but the adipose tissue is surrounding the kidney together with the suprarenal gland. We can distinguish in the middle part on a section, so-called the medulla in the suprarenal gland, and the cortex is on the periphery and the medulla is in the center. So, what is interesting on the blood supply in the suprarenal gland? So here in the capsule you see the arteries in the capsule, the arterioles which are entering already the cortex, and the capillary net in zona glomerulosa. I will explain in a few minutes. Then you see here such cortical sinusoids running into such a next capillary net more in the zona reticularis. So this is one system of blood running to the medulla, because all the cells which are in the cortex here, in the cortex, are producing hormones which has to get into the blood. And now the second system, which is seen on the side here, is such a small arteriole which is running through the whole cortex and dividing into a capillary net in the medulla, as you see, till here. Here are capillaries. And those system of those small arterioles are called arteriae perforantes, and they are not dividing into a capillary net in the cortex, they are dividing into a capillary net in the medulla, as you see. So the blood supply for the medulla is, and for the cells in the medulla, is much quicker by the system of arteriae perforantes, which are running through the whole cortex directly to the medulla. And what's the second typical sign on the slide? We will see in the medulla typical big veins. Medullary veins are seen in the center of the medulla of the suprarenal gland. So I have said trabecular epithelium. Trabecular epithelium. The trabecules has different shapes and different runnings and different localization. So here under the capsule, which is here, this is a capsule from the connective tissue. The first layer, which is approximately here, I would say the first zone is this one. And you see that, and we can see very nicely that the trabecules of the epithelial cells are not straight. They are like rings, or they are horseshoe shaped, or they are completely forming a ring, round. So that's the reason why it looks like a glomerulum, this system of trabecules. So the first layer of cortex is called zona glomerulosa. The second. Now we see that the trabecules are not orientated in rings, but they are straight, nicely seen here, straight, running parallelly to one to another. Here you see it very nicely. And the arteria perforantes running between them. And they are straight, the trabecules. They are running parallelly one to another. And approximately, as you feel it, approximately, I will do it up to the capsule, and approximately 90 degrees to the capsule. So this is the sickest part of the cortex, the sickest part of the cortex, and this is zona fasciculata, the second. And now in this part, you see the trabecles are completely irregular, forming a very strange irregular net. And the third part of the cortex is called zona reticularis. So this is the cortex, zona glomerulosa, zona fasciculata, and zona reticularis. And then you are in the medulla, in the cells of the medulla. So trabecular epithelium and the trabecles can have, and they are having a different shape, and that's the reason why these three zones are here so nicely seen. Zona glomerulosa, nice, perfect, important first zone, just under the capsule. You have seen it now a few minutes ago with this ring or horseshoe-shaped trabecles, producing mineralocorticoids, aldosterone, for example. Aldosterone, yes. So, and here is a function of aldosterone, very important function, yes. Having influence on the cells in the distal tubules, in the kidney, aldosterone. Maybe you have heard already, yes, I was saying today already the name renin, a hormone produced in the kidney. Renin has influence on the angiotensin system, converting angiotensinogen 1 to 2. Angiotensin 2 is having influence on the cortex here in the kidney to produce more aldosterone. So the system is renin, angiotensinogen, aldosterone, called the system. Here is a mark, Kohn, Mr. Cohn's syndrome is an unpleasant disease when a big production of aldosterone, higher production of aldosterone, which is called in another name hyperaldosteronism, Cohn's syndrome means that in this moment when this disease is possible here or is coming, so logically sodium is staying more in the body, in the blood. Behind sodium runs automatically water. That means there is a higher volume of water, in the blood. Yes, in the blood plasma is more water. When you have such a big volume of water in your blood system, it's not good because it's increasing the blood pressure of the patient. So the blood pressure is rising, and now can come the complications of the high blood pressure for the patient. So this is a Cohn's syndrome, and the bigger production of aldosterone is here the reason why it can be. You will hear on pathology what can happen in the zona glomerulosa, in the suprarenal gland. Zona fasciculata are producing glucocorticoids. Yes. The most important, for example, is cortisol. Yes, and some androgens. So, I think that you have remembered from adenohypophysis as adrenocorticotropic hormone regulates the secretion of cortisol, for example, in this moment. Here is the name of another gentleman. This was an American doctor, Mr. Harvey Cushing, that described in year 1932 this disease, Cushing syndrome, and that means once more a higher level of cortisol in the blood. That means when you have a higher level of this cortisol, that means you have hyperglycemia in your blood, higher level of glucose in your blood, hyperglycemia. This is not very good situation to have hyperglycemia because very simply can go your body weight higher. So the patient has problems with obesity in few weeks, months, and this higher obesity and higher weight of course increasing the blood pressure once more, and the result can be that at these patients is starting diabetes mellitus type 2. This is the most unpleasant complication of this higher level of cortisol in the blood, and this is called the Cushing's syndrome. Zona reticularis. The last, some glucocorticoids and androgens producing. Yes. So, the trabecles are running in all directions. That's why it's called reticulum net, and that's the reason why it's called zona reticularis. This third zone very near the medulla. Here you see a nice picture, but not stained with hematoxylin eosine, but this time stained with oil red. So here is a borderline. This is the cortex. Here is the medulla. And here we see zona glomerulosa, zona fasciculata, and here zona reticularis. This is a capsule. And this time you see by oil red, this is a dye which can show you lipid droplets in the cytoplasm of cells. And why I'm starting to speak about lipid droplets? Because the cells, of course, are producing steroid hormones in the cortex. So these are cells with a typical characteristic producing steroid hormones. That means you see those small lipid droplets we see by oil red with a nice red color. Oil red is staining in a red color those small lipid droplets in the cytoplasm. So this is one of the first rules, many small lipid droplets in the cells. The second is mitochondria, as you see here, mitochondria tubular type, mitochondria with tubules. You see on a cross section, the inner membrane is forming the tubules very nicely. The third thing, smooth endoplasmic reticulum in the cytoplasm, smooth endoplasmic reticulum, as you see, yes, here, yes, smooth endoplasmic reticulum, and the cytoplasm is eosinophilic in this moment, eosinophilic. So these are the basic rules and basic characteristics for the cells producing steroid hormones, mineralocorticoids, glucocorticoids, and androgens. The cells are called sometimes, generally with small lipid droplets in the cytoplasm, with the cytoplasm nucleus, and the small lipid droplets in the cytoplasm, small lipid droplets with cholesterol, because you need cholesterol for the production of steroid hormones. So they are called the cells sometimes, generally, spongiocytes. Spongiocytes are called the cells containing small lipid droplets. Yes. So we can call them spongiocytes. Here are the cells in the cortex of the suprarenal gland. The medulla. So you see here is a small piece of the still zona reticularis of the cortex, and those cells are already in the medulla. So there are two basic types of cells in the medulla. One type of cells are producing epinephrine, adrenaline, epinephrine, about 80% of those cells, and about 20% of those cells present here are producing norepinephrine, or in another name, noradrenaline. They are both catecholamines, epinephrine, and norepinephrine. So you see such irregular trabecles or clusters or groups of those cells. The granules with the hormone can be stained with salts of chromium. So we call them chromium or chromaffin cells, thanks to the possibility that we can stain them with the salts of chromium. They have then the result, the cytoplasm of those cells has such a yellowish brown color. And here in the medulla you see already the typical veins, and a bigger vein running in the center of the medulla, because the blood is taken out from the whole suprarenal gland by one suprarenal vein. Here you see a scheme of cell producing norepinephrine, and here's the granules with the hormone. What is nice, it's very well done, the scheme, because you see the electronogram, yes, and you see that the density, a very strong density is in the center, and there is a short rim which is not dense, is lucent around this dense center, around this dense center. So those granules with a dense center and the light rim around, these are typical granules of norepinephrine in this norepinephrine cell. And you see a lower density, such a middle density of the granules on the cell producing adrenaline, or in another name, epinephrine. So you can also distinguish from the electronogram, thanks to the density of the granules, which cell is a norepinephrine producing cell and which cell is an epinephrine producing cell. And in the end, a few words about the pancreas. So the exocrine part, the endocrine component, exocrine component. Exocrine we have seen on the slide already, because you remember, I hope, serous cells which are lining serous acini in this gland, and now the system of ducts, this intercalated ducts, and then the interlobular ducts and the main two ducts leading the secret to the duodenum. This is the exocrine part of the pancreas. And the endocrine part of the pancreas is represented by the islets of Mr. Langerhans, the islets of Mr. Langerhans. Paul Langerhans was a German doctor. He was working on anatomy, pathology, and he described those islets 1 year after he ended his studies, 1 year after ending his studies in Berlin, the University of Berlin, and he described them in the year 1869. Those islets he has seen for the first time in the slides of pancreas. Of course, in this year he could not understand the cells inside and the function of those cells, because I don't know if you know, but insulin was given to this world in year 1920. So you see, approximately 50 years after Paul Langerhans described those islets, but 50 years after then was given at last insulin. So here you see nicely the pancreas, the little bit anatomy, then the head, caput, then the part which we call column, then is the body, corpus pancreatis, and the cauda pancreatis is touching here the spleen. So you see nicely the pancreas, you see the two main ducts coming out to duodenum here. So, and we are back in histology, and we are speaking once more about the trabecular epithelium. Trabecular epithelium, and these secretory cells in the trabecular epithelium are perfectly surrounded by fenestrated capillaries. A healthy human should have between 0.5 to 1.5 million of islets of Langerhans in his pancreas. The biggest amount is in the body and in the tail of the pancreas of the islets. And here we see this round structure, an islet of Mr. Langerhans, and here an islet of Mr. Langerhans. So here are two. But this time it's not a basic staining method, it's immunohistochemistry here, immunohistochemistry. So now the types of cells in each islet. So the cells producing this hormone glucagon are so-called alpha or A cells, the number in a healthy human. The biggest number, of course, are cells producing insulin, beta or B cells, the pancreas. D cells, a very low number of D cells producing somatostatin, yes. Then we have the PP cells, double P, PP cells, producing PP, pancreatic polypeptide, next hormone, and a little amount of so-called E cells producing ghrelin, because ghrelin, this hormone, is produced mainly in the stomach, in the diffuse neuroendocrine system in the stomach, in those cells, but as well few cells in the pancreas can produce this hormone. So here by immunohistochemical methods you see the brown color of the cytoplasm of A cells. So you see that there are approximately 20% present in this islet of pancreas. Here you see the fenestrated capillaries nicely, yes, around the trabecular epithelium, yes. Here you see a higher level of brown color on this islet. So it means that 80% are really, at a healthy human, are present B cells producing insulin. These two hormones are antagonists, please. These two hormones are antagonists, yes. Insulin having influence on many cells in our body, which has receptors, and by those receptors, maybe you have heard this GLUT4. They are taking glucose from the blood and storing glucose as glycogen in their cytoplasm. Glucagon is working quite the opposite, that the cells has receptor for glucagon and the cells are releasing glucose back from the cytoplasm into the blood. This would be so very easily set the basic function. So the level of glucose is very important in the blood, yes. 3.9 to 5.6 millimoles on 1 liter of blood, millimoles on 1 liter. Higher level of glucose is hyperglycemia, lower level of glucose in your blood is hypoglycemia. Once more, glucagon and insulin hasn't got any hormone from the hypophysis. That would be such a chief hormone for those two. The cells are reacting in the production on the level of glucose in the blood, B cells and A cells. Glucagon is a smaller polypeptide, only 38 amino acids. Insulin is composed from 51 amino acids. So this will be later in biochemistry and in physiology, the structure of insulin. Here you see a nice islet of Langerhans stained with hematoxylin eosin. So you see there is no help how to distinguish A cells and B cells. You see they are stained completely the same. You see the nucleus, but now which one is the B cell and which one is the A cell? So you need once more perfect immunohistochemical methods to distinguish the cells. Slightly can help aldehyde fuchsin. Aldehyde fuchsin is a dye, and this aldehyde fuchsin has affinity to B cells. That means we can see slightly in an islet by this staining, slightly a bluish color, a blue color of B cells. So it can be such a little more precise staining method to distinguish slightly B cells in the islet of Langerhans. And this is showing a typical carmine perfusion in the blood, a dye into the blood given, and you see the system of fenestrated capillaries around the trabecular epithelium in this islet of Langerhans. So there is a perfect vascularization in each islet of Langerhans, that you can see it by this method, to push a dye into the blood, and then you see on a slide where is this dye in the vessels, nicely seen around the trabecular epithelium. So my lecture was 7 minutes longer. Thank you for your listening and for watching the pictures, and I hope that you are more now clever about some endocrine glands and also a little bit about some clinical corresponding information, for example about the Cohn syndrome or the Cushing syndrome. So I think that it will be a help for your practical courses and for your final exam. Thank you and goodbye.